This conference will now be recorded.
So preterm labor and birth. What is birth occurring before 37 completed weeks of pregnancy is called a preterm labor. What is a suspected preterm labor? When the patient is feeling labor pains, but the cervix is closed, then we will say that we are suspecting preterm labor. Prophylaxis. So if you have diagnosed of preterm labor, so you should offer progesterone or cerclage to the woman. If the patient has history of previous preterm birth between 16 weeks to 34 weeks, and you have done the ultrasound scan, and the length of the cervix is less than 25 millimeter, then we can, between 16 to 24 weeks, then we can give them cerclage. This is the or if the patient is not accepting cerclage, then we can give them high dose progesterone. Okay. That is all the total we need to remember here. Then these women who have, where you have done ultrasound and they are between 16 to 24 weeks, and the scan has shown that the cervix is less than 25 millimeter. So then you are going to offer them progesterone. And why you are going to give them progesterone? Why you are not giving them any cerclage? Because they have no history of previous preterm birth. All of these are EMQs, SPs. You should consider cerclage for a woman where the scan has shown that the length of the cervix, transvaginal scan, okay, it has shown that the length is less than 25 millimeter at 16 to 24 weeks. There is history of pre-labor, premature rupture of membranes, or if there is history of cervical trauma. What can be the history of cervical trauma? Like we did the cone biopsy. It was history of cone biopsy or LACE. They are associated with increased risk of PPROM like that. So then what is rescue cerclage? Rescue cerclage you are going to consider from 16 to 27 plus 6 weeks with exposed unruptured membranes, and don't offer if there is infection, active bleeding, or there are contractions. So that's all you need to remember about cerclage. You should know these timings, these weeks very precisely because they are important in making some decision. How do we diagnose PPROM, premature pre-labor rupture of membranes? By history, we will take the history, and for the objective testing, we are going to do the speculum examination. If no pooling, then we should consider what is this insulin-like growth factor.
Growth factor, no?
Done, or we can do the PEMG test. Any one of them can be given. Okay. If there is no pooling. If the test is positive, you should offer care as PPROM or re-evaluate at a later date. If the test is negative, any one of these are the amnicio test, right? So these tests are negative. We are not going to give them any antibiotics. That is important. Test is negative, don't give them any antibiotics like that. So antibiotics, when they should be given? We can give oral erythromycin 250 milligrams QID maximum 10 days. Okay. Use penicillin if the patient is not tolerating erythromycin. So preterm labor with intact membranes established by the studies, and the likelihood of the birth is within at less than 24 hours.
Do we give penicillin or vancomycin?
We can give vancomycin. Vancomycin is
the new guidelines, I think, says vancomycin.
Vancomycin, erythro, then vanco, and then we can give them the other. Like if they are allergic, then we can give them cephalosporins can be given like that. Okay, so erythromycin or vancomycin. Why we don't give clindamycin? Because the resistance index is very high. That is as high as 17 to 19%. Okay? So if you are suspecting preterm birth at less than 29 plus 6, then you need to treat for preterm labor. Suspected preterm labor if at more than 30 weeks. If it is at less than 30 weeks, that is 29 plus 6 weeks, then you are going to treat for preterm. Now, if the baby is suspected preterm at more than 30 weeks, so it is still going to be preterm, but we will do the transvaginal ultrasound. If the cervical length is more than 15 millimeters, then it is unlikely that the patient has preterm labor. If it is less than 15 millimeters, then we are going to treat for preterm labor. So further management will depend upon the cervical length. And what are we going to use? We are going to use the transvaginal ultrasound. If the cervix is longer than 15 millimeter, then it means that the patient is not in labor. And if it is like less than 15 millimeter, then we know that the patient is in the preterm labor. So we are going to treat that for the preterm labor. Suspected preterm labor at more than 30 weeks and no ultrasound available, then what test you can do? You can test for fetal fibronectin. So 50 nanograms per ml, that is the cutoff. Okay? If no ultrasound available and you are suspecting birth, the preterm labor after 30 weeks, so what you can do, you should check for fetal fibronectin. This fetal fibronectin has very high negative predictive value. If it is negative, then it means that your patient is not going to deliver in the next 7 days. That is the point. So if it is fetal fibronectin is more than 50, so it means that your patient is already in labor. So then how we are going to treat the preterm labor? We are going to give nifedipine. Why we are giving this nifedipine? For the neuroprotection. We should consider the age of viability is going to be 24 weeks. So we should consider it between 24 to 25 plus 6 weeks. And we should actually offer at 26 weeks to 33 plus 6 weeks. That is the ideal duration for tocolysis. Corticosteroids, when are we going to give them corticosteroids? So the corticosteroids, 24 weeks to 25 plus 6 consider, but offer between 26 to 33 plus 6 weeks. And consider from 34 to 35 plus 6 weeks. That is the point, okay? Third thing that you need to give to your patients is the magnesium sulfate. What is the benefit of magnesium sulfate? Neuroprotection, okay? So what are the indications? You will give magnesium sulfate if you are anticipating birth in less than 24 hours, okay? And you should offer between 24 to 29 plus 6 weeks, okay? And in some cases, you will have to consider from 30 weeks to 33 plus 6 weeks, okay? How we are going to give, just like we give in cases of preeclampsia, okay? 4-gram bolus, very slow over a period of 20 minutes, and then we are going to give 1 gram per hour and observe. We are going to carry out full set of assessment like the respiratory rate, reflexes, every 4 hours. Why? Because if the patient loses her deep tendon reflexes, like the knee reflexes loss, so it means that is the first sign of near this neurotoxicity of this magnesium toxicity. Patient's knee reflex will be lost. We call it deep tendon reflex will be lost. So loss of deep tendon reflexes. Then your patient can have respiratory paralysis. Okay. So then she can have other muscles paralysis, then she can have renal shutdown. Okay, so that if all of these, when they set up, then we say that the patient is having magnesium toxicity. So the therapeutic level of the magnesium sulfate should be 4 to 7 milliequivalents. Okay, that is the therapeutic one. If it is more than 7, then it means that you need to give something to the patient. So what will be that something? Calcium gluconate. How much? What should be the concentration? 10% calcium gluconate, 10 ml should be given intravenously over a period of 10 minutes. Okay, so this is
10, 10,
this
10.
is calcium, yeah. 10, 10, 10 calcium carbonate. The rule of 10, you know that. Okay, so we are going to give it. So then another thing, another sign of toxicity can be like the patient is not passing urine. So because this is a relaxant, okay, so the if patient is not passing urine, it can be nephrotoxic also, okay, in some patients, like if they have underlying renal disease. So first of all, if you have the history of renal disease, then you are going to decrease the dose of magnesium sulfate. Like instead of giving like you will give this bolus, but then for the this maintenance of this infusion, you can give her like half gram per hour, or that is the point, okay. And how you will know that the patient's kidneys are affected? Because the urine output will
But will be
decrease.
reduced.
So the minimum urine output should be 30 mLs per hour. Okay, but if it goes to like 25 per hour, then you will have to stop the drug and you will have to hydrate the patient. Okay, so once the patient improves, you can restart like that. Okay, so then if you need to monitor the patient every 4 hours like that. So never forget the baby. All of these things are part of like full management, like you are assessing the mother and you are assessing the baby. So you're going to do CTG to interpret as per term. Then as in cases of the term baby, so you will have to do the CTG. Then fetal scalp electrode you can use if the baby is more than 34 weeks. Okay, 34 weeks or more than 34 weeks. Before that, you should not be applying any fetal scalp electrode like that. So then there are certain prerequisites for the fetal blood sampling also, like the fetal blood sampling we are going to offer if the baby is like 34 weeks or more. So use of Mexel in the preterm deliveries for neuroprotection of the baby, it can be carried out. And then you should remember that what type of cerebral palsy we can see in the preterm, that is going to be diaplegia. Okay. Like that both limbs, they don't have sensation. Then prematurity, it accounts for 35% cases of the cerebral palsy. And there are two mechanisms of cerebral palsy in cases of preterm babies: intraventricular hemorrhage and paraventricular leukomalacia. And cerebral palsy, it can occur in 2 to 3% of the babies where the birth weight is less than 1500 grams. It can be due to inflammation from the maternal or the fetal infection. So how much Mexel we are going to give? The same dose, 4-gram bolus over 30 minutes, and then we are going to give 1 gram per hour.
Per hour.
So you should aim bolus within 4 hours of the birth. It can be, maintenance has to be kept for up to 24 hours. The effect is modest effect on cerebral palsy in meta-analysis only. What is the number needed to be treated to prevent one case of cerebral palsy at less than 30 weeks? You will have to treat 46 patients. You will have to give Mexel, they like to ask these questions. You will have to give magnesium sulfate to 46 patients if you want to prevent one case of cerebral palsy. So these are important things, important points for you. Any question, anything so far?
No, it's clear. Yeah.
So then there was this another guideline, PPROM, from the RCUG like that. Okay? So let's go over that one also. Yeah, actually the preterm. So the term, that term is 37 weeks. So the preterm can occur at 37 weeks of the gestation or more. So the salient points would be streptococci, prophylaxis is indicated. Okay, treat intraamniotic infections if they are present, okay? And proceed towards delivery, like we can offer induction of labor or we can do cesarean section as indicated or appropriate for that case. Okay, so if it is late preterm, like 34 weeks to 37 plus say, then expectant management or proceed towards delivery and induction or cesarean as appropriate. Single course of corticosteroids if steroids not given previously. If proceeding with induction or delivery in no less than 24 hours and no more than 7 days and no evidence of chorioamnionitis, then single course of steroid is going to be fine. GPS screening and prophylaxis as indicated. Treat intraamniotic infections if they are present and proceed towards delivery. The preterm, like when the gestational age is between 24 plus 7 to 24 weeks to 33 plus 6 or
3.
7 weeks of gestation, can be up to 37 weeks of gestation. So you are going to offer expectant management. Antibiotics, they are recommended to prolong latency if there are no contraindication, like no sepsis, no bleeding, nothing is there. So you can, and no fetal compromise, then we can give it to them. So we are going to give single course of corticosteroids because there is insufficient evidence for or against rescue courses. So treat intraamniotic infections if they are present and proceed to delivery. Take a vaginal or and rectal swab for GBS culture. It should be obtained at the time of initial presentation and GBS prophylaxis administration as indicated. Make cell for neuroprotection before anticipated delivery and better, and you can give if they are less than 32 plus 7 weeks and if they have no contraindication. Now, if the baby is pre-viable, like less than 23 to 24 weeks of gestation, then you will offer patient counseling, consider neonatology and the maternal fetal medicine consultation, expectant management or induction of labor. Antibiotics, they should be considered as early as 20 weeks of gestation. GPS prophylaxis is not recommended before the age of, so no GBS, no corticosteroids before the age of viability. Procolysis is not recommended before viability. Magnesium sulfate for neuroprotection is not recommended for viability. So that is a simple table to explain that what actions you should take according to the specific gestational ages. Okay. So you don't have to do like so many different things. Just remember the main points like that.
Okay.
So any question, any problems so far?
No, it's clear so far. It's okay.
Let's see if we find something else. So that is the simple management, and then we can see preterm labor. Okay. So preterm labor means that we are going to deliver before 37 weeks of pregnancy, and we should know that this is a major cause of neonatal morbidity and mortality, and stillbirth 5 to 10% in cases of in the developed countries. And if it is like less than 8% of the live born babies, they are born in the third world, okay? They are born preterm. Preterm birth between 28 weeks, then 0.6% they are going to be extreme preterm. Extreme preterm means like they're going to have more and more problems before they're between 23 to 24 weeks of pregnancy like that. So the major problems, you know that what problems can be there. Rest of the things exactly the same, that how we are going to manage them. The same things like I have revised for you. So everything is essentially the same. Okay? That is the point. We're not going to delay labor or anything. We are going to give the full medicines and then we are going to do assessment. And then you should know very well that who is going to be on the team, who is going to evaluate that baby. Okay? So who should be on that team? Like we are seeing the patient as obstetrician, who else should be looking at that baby?
The pediatrician.
Yeah, pediatrician, neonatologist, they all should be there. Like so very simple points. Like everything is essentially the same. Like I revised for you, I summarized that for you. The same tests we are going to do. So I don't want you to go to multiple sources. Okay? Like the way we have discussed, that is going to be enough right now. Just remember the incidences that PPROM affects like 3% of the pregnancies and 40% of the preterm births like that. That is one thing. Rest of the things are essentially the same. Okay, you are taking the history and then you are doing these tests, and then on the basis of you're using the amniture and then you are assessing your patient. Okay? These are the points. Then why do we give antenatal corticosteroids? What is the benefit of giving them the steroids?
For the lung maturation, for the RDS, to prevent them from RDS.
So it will decrease the risk of three things. It is going to decrease the risk of RDS, And how much? By 46%, by 44%. Okay, it will decrease the risk of, yeah, this, it will decrease the risk of interventricular hemorrhage by 46%, and it will decrease the risk of necrotizing enterocolitis by 33%. Okay, these are important. Respiratory distress, it will decrease by
40%. Yes.
44%. Okay, that is the point. And otherwise, you will have to give them other things like that. And the interventricular hemorrhage, the rate will decrease by how much? By 46%. And the respiratory and the intraventricular necrotizing enterocolitis, it will decrease by 33%. So these are the numbers that you need to remember. Now, rest of the things are like the analgesia and labor and everything. So they are all present in your notes. So this labor, it's a very, very lengthy one, very lengthy module.
Yeah.
Like, okay, that is one thing. So anything regarding preterm, please tell me about it.